everyone. We are here for the Society of Skeletal Radiology Resident Education Club, and I'd like to welcome Dr. Vishal Desai. Dr. Vishal Desai is an assistant professor of MSK Imaging and Interventions at Thomas Jefferson University. He completed his residency and MSK fellowship at Jefferson and serves as the assistant fellowship director. His research interests are focused on informatics and clinical applications, in addition to imaging, classification of sports injuries, and assessing patient outcomes after image-guided interventions. So please, let's welcome him. And once he's done with his presentation, we'll be fielding your questions in the Q&A space, and we'll have a nice conversation. Dr. Desai, please take it on.
Thank you for the introduction, Jenny, and good evening, everyone. I'm going to go over ankle MRI today, a bit about my approach and some classic cases. I asked our residents which joint and which set of pathology they're least comfortable with, and universally they answered ankle. So I thought this would be a good time to review some of those concepts, go over some classic cases. I'm going to focus on ankle-specific pathology, particularly acute injuries and painful conditions, things like OA, neoplasms, and things that happen in other joints. I'm not really going to discuss today. It is an interactive lecture, so feel free to join and kind of play along as we go through this. So ankle MRI, as you're probably all well aware, ankle MRIs have a lot of findings. We've all probably sprained our ankle at some point, and the sequelae of that may still persist on imaging. For that reason, a systematic approach is key when you open up an ankle MRI. First, I usually pull up the history sheet. Is this an acute injury or is this a chronic pain pattern? If it's an acute injury, how long has it been? Is it, where does it hurt, and what was the mechanism of injury if they choose to provide that information? Next, I usually look at the bones. Is there a normal marrow signal? Is there any contusion? Is there a fracture? Take a look at our joint spaces next for effusion, synovitis, and any cartilage defects. And then the most high yield in the ankle is going to be the ligaments. Almost every ankle injury pattern is going to have some sort of ligament injury included with it. So take a look at your ligaments in detail. The ligament pattern of injury may clue you into the mechanism or vice versa. Tendons, also many tendons in the ankle, several with multiple functions. So go through it systematically. I'll start with the medial ankles tendons, your PTT, your FDL and FHL. Move on to your lateral tendons, your peroneal tendons. Take a look at your anterior tendons. Finally, ending with Achilles, and usually I'll lump the plantar fascia into this part as well. Last, take a look at the soft tissues. One of the key philosophies of MSK MRI is follow the edema. So finding soft tissue edema may clue you into where the injury is. For today, we're going to go over common ankle injuries. We're going to look at several causes of medial and lateral ankle pain with a focus on tendinopathies. We're also going to go through several causes of posterior ankle and heel pain. And finally, we'll take a look at a few cases of midfoot pain. The midfoot is included on your ankle MRI, and patients likely are not going to differentiate midfoot versus hindfoot. So let's move on to our case number one. So for all of these, I'm going to show the PowerPoint slide first, then we'll move on to the poll everywhere question because I can have the images blown up here. And since we don't have the luxury of scrolling through these images, I will help you highlight the areas of interest to clue you into the answer. So case number one, this is a 30-year-old female with ankle pain after soccer injury. The area of interest on this one will be here, over here, here, and then a more normal structure higher up. So moving on to the question, select the ligament or ligaments involved. You have your AITFL, your ATFL, CFL, interosseous ligament, deltoid ligament, or bifurcate ligament. So I'll wait for about 20-30 seconds, let those answers roll in, then we'll kind of collect those responses and go over it. Okay, so we have about 20 responses so far. Okay, great. We'll go with that. If you didn't get to play along on this one, there are several more questions. So looks like we did pretty good here. So the correct answers were ATFL, the CFL, and the deltoid ligament. So this was an ankle inversion injury. In this case, we had a complete tear of the ATFL. a partial tear or a grade 2 sprain of the CFL or calcaneofibular ligament, likely a contusion of the deltoid ligament with adjacent osseous contusions, and we had an intact AITFL or anterior syndesmosis. So we'll go over all of this in detail at the end. Let's move on to another similar case of an ankle sprain. This is a 22-year-old male college football player with ankle injury 2 days prior. So I'm going to kind of highlight the areas of interest again for you. So going higher up, we have this structure here. I will kind of clue you in that the proximal extent of this injury was not included on the field of view of the MRI. And last on this image here. So for the question, what is the next best step? So a bit of a two-part question, figuring out what the injury was, and then what would be the next step. So would it be X-ray of the contralateral ankle, X-ray of the proximal tib fib, CT of the foot, MRI of the forefoot, or an ultrasound? Okay. Another 20 seconds or so. Perfect. Looks like a large majority got that correct. So the correct answer here was X-ray of the proximal tib fib. So this was a patient who had a high ankle sprain with a tear of the anterior syndesmosis or AITFL, probably a sprain of the posterior syndesmosis or PITFL. He had disruption of the interosseous ligament that tracked upwards into the interosseous membrane. As I said, we did not see the proximal extent of that interosseous membrane injury. That force can get transmitted all the way up along the interosseous membrane and cause a fracture of the proximal fibular neck, the so-called Mason-New fracture. And it also had some tearing of the deltoid ligament. So last case in the ankle sprain segment. This is a 25-year-old male soccer player with ankle pain after twisting. We have 2 slides with images here. I'm going to point out the area of interest here, a normal structure a little higher up, and then the more important slides here. So just kind of highlighting the areas to focus on. Then we'll move on to the question. Okay, so what is the diagnosis? Is this a high ankle sprain, a lateral or low ankle sprain, a mid-tarsal sprain, subfibular impingement, or Charcot arthropathy? Okay, got some answers rolling in. Okay, another 10 seconds. Okay, so, I can see why this was chosen because of the one slide that I showed with the ATFL sprain. The correct answer was a mid-tarsal sprain. This is a very under-recognized injury. In this case, we had some avulsive edema at the anterior process of the calcaneus. We had a sprain of the dorsal tail navicular ligament, a sprain of the dorsal calcaneocuboid ligament, and then we'll go over what all of this means coming up. Okay, so we went over 3 cases of very common ankle sprain patterns. Let's get into the details. So first we have our lateral or low ankle sprain. This is our ankle inversion injury. This is that injury that we've all had at some point, whether we're playing sports and we twisted our ankle or we stepped off a curb and rolled our ankle. So just to kind of help you put this in better perspective, if you take your ankle right now and turn it inwards, you'll feel that stretch on your lateral ankle and your lateral ligaments. So in this injury, this is where you're going to get tearing of your ATFL, your anterior talofibular ligament, and your calcaneofibular ligaments. On the medial side, things are going to get compressed with that inversion injury. So that deltoid gets squished between your medial malleolus and medial talus, often ending up with a contusion of the deltoid ligament. On X-ray, depending on the relative strength of the ligaments relative to the lateral malleolus, you may end up with an avulsion fracture. And then we talked about the possible osseous contusions on MRI of the medial malleolus and medial talus. Most of the time, these will heal either with no imaging findings remaining or scarring or attenuation of those ligaments. In patients with high-grade injuries or recurrent sprains, they may end up with chronic ankle instability. So in diagram format, here's that inversion of your ankle leading to tearing of your ATFL and your CFL, and a contusion of your deltoid ligament complex. On imaging, this was a case that we had. Normally, we have a nice black structure, your ATFL, running from your anterior talus over to your lateral malleolus. In this case, we have a complete tear of that ATFL. In this one, we have intrasubstance signal and periligamentous edema of the CFL, so a grade 2 sprain or a partial tear. And here we have osseous contusions at the medial malleolus, the medial talus, and the deltoid ligament gets squished and contused right in between that. So moving on to high ankle sprain. So this is a different mechanism. This is going to be external rotation. So if you take your foot right now, plant it on the ground and turn it outwards, you'll feel that stretch at your distal tib fib and along that medial ankle or medial malleolus. So when that happens, this is going to cause injury to the syndesmotic ligaments. First to get injured is going to be your AITFL, your anterior inferior tibiofibular ligament, the major component of the anterior syndesmosis. Next will be your PITFL, your posterior inferior tibiofibular ligament, the major component of your posterior syndesmosis. That force can then get transmitted up to the interosseous ligament, which is the lower extent of the interosseous membrane. Then that can go even further up along that interosseous membrane, which is a big fibrous band between your entire segment of your tib fib. And like we were talking about, that can get transmitted all the way up and cause that fracture of the proximal fibular neck, the Mason-New fracture. When you're doing that stretching, you probably felt that when you're doing that maneuver, you probably felt that stretch at that medial ankle. That's where you can end up with tearing of the deltoid ligament, particularly the deep fibers. And on radiograph, that can present as widening of that medial clear space, since that deltoid plays an important role in maintaining stability of that medial tibio-talar joint. Because these are rarely purely one mechanism or the other, you may end up with concomitant sprains of the ATFL and CFL. We talked about the widening of the medial clear space. We talked about syndesmotic widening because of syndesmotic injury. The other X-ray finding you may have here is a fibular fracture. This is where your Weber classification comes into play. So the level of the fracture can guide you to the possible degree of syndesmotic injury. So below the level of syndesmosis, a Weber A, B at the level of syndesmosis, or C above the level of syndesmosis. All of these ankle sprains, but in particular high ankle sprains, may be associated with osteochondral lesions in close to 30% of patients with high ankle sprains. And as opposed to your standard ankle inversion injuries, the high ankle sprains usually have longer rehab and may require surgical fixation. So that kind of plate and screw fixation along the lateral malleolus with syndesmotic screws or sutures. So in diagram format, this is your foot rotating outwards, your tib and fib remaining in place or actually rotating inwards, causing tearing of the interosseous membrane and your syndesmosis. So on imaging, starting at the inferior end, we have tearing of the ATFL, may or may not be present in a high ankle sprain. We have a complete tear of the AITFL, the anterior inferior tibiofibular ligament, part of the anterior syndesmosis. There was a sprain of the posterior syndesmosis. And then as we came higher up, the interosseous ligament was torn, the interosseous membrane was disrupted, and we also had tearing of the deep fibers of the deltoid ligament complex. This patient did get x-rays of the ankle and the tib fib. There was not widening of the medial clear space and no Mason-New fracture was present. Okay, for medial ankle sprain, I'm going to breeze through this one. It's very rare to get this in isolation. This will be your ankle eversion injury, so your foot turning outwards. This will lead to stretching and tearing of your medial ligaments, in particular your deltoid ligament complex, both your superficial and your deep fibers. On X-ray, because the deltoid ligament is quite strong, this may lead to a medial malleolar avulsion fracture. The main takeaway from this section should be that a deltoid ligament sprain in isolation is very rare. More commonly, deltoid injuries are going to happen with high ankle sprain or your inversion injuries, and less likely from an eversion injury. So here's that same thing in diagram format, your foot turning outwards, causing that tear of your medial ligaments. I searched through our packs for any indication or impression that mentioned eversion injury. I had to go a few years back to find a case. It looks like we do have tearing of the deep and superficial fibers of the deltoid here, along with edema within the medial malleolus. I suspect that this was not a pure eversion injury since we also had a sprain of the ATFL. So moving on to midtarsal sprain. So this is one of the most under-recognized sprain patterns in the ankle, and then we'll kind of go over what you should look for. So the mechanism is also going to be an ankle inversion injury, but the foot is slightly plantar flexed. So that the force gets transmitted across the show part joint or your mid-tarsal joint, which is your talonavicular and your calcaneocuboid joints. Several ligaments and several osseous structures may get involved with this. So you've definitely seen some of the X-ray findings that go along with this. So you can get a sprain of your dorsal calcaneocuboid ligament. So on your axial slice, you'll see your calcaneocuboid joint. You'll see an infusion there with sprain of the joint capsule, the dorsal calcaneocuboid ligament. Similarly, on your sagittal, you have a sprain of the dorsal talonavicular ligament with a joint effusion usually pushing up through that. And with those, you may see avulsion fractures. We've all seen those little capsular avulsions on your lateral view on an X-ray of the dorsal talar head or dorsal navicular. They can happen in isolation, but they may be associated with the mid-tarsal sprain, so look for your additional injuries. The bifurcate ligament, this is a Y-shaped ligament running from your calcaneus with attachments to the cuboid and the navicular. This can lead to, of course, the ligament can get sprained, but because it is a strong ligament, it may lead to avulsion of the anterior process of the calcaneus, or in the case that we had, just some avulsive edema on the anterior process. So look for your concomitant findings if you have one of these. If these patients have premature return to activity, they may have persistent pain and instability. So let's go through that. This is going to be an inversion injury with a bit of plantar flexion. You'll have injury to the dorsal calcaneocuboid, your dorsal talonavicular, and this is your bifurcate ligament, possibly with osseous avulsions. The much less common form of a mid-tarsal sprain is going to be an eversion injury, as opposed to all of those ligaments getting involved. This may lead to an injury to the spring ligament, and you'll end up more of an impaction injury across your calcaneocuboid. It's quite rare to get this. This is way, way, way more common. So radiograph and CT. So this patient came in with twisting injury, found to have this little dorsal avulsion of the navicular. Further injury was suspected. Looks like that force was likely transmitted across that show part joint here. The anterior process calcaneus was intact, but went on to get CT, and he did have an avulsion fracture of the calcaneocuboid. So on MRI, because the injury pattern is also an inversion injury, the ATFL may get injured in this process, which we have here. The syndesmosis, because this is a separate mechanism, should be intact as it is here. And then the important sequences or important images. So in this case, this was the one that we had. We have that avulsive edema at the anterior process of the calcaneus. It was not fractured, but this is an injury to the bifurcate ligament. Here's that sprain of the dorsal calcaneocuboid ligament with that associated joint effusion. And here's that sprain of your dorsal talonavicular ligament. We have some avulsive edema at the dorsal talar head and also a joint effusion. Okay, all of these ankle sprains, but in particular the high ankle sprains may be associated with osteochondral lesions. Most commonly in the ankle, they're going to be at the medial or lateral talar dome. This in itself can be a whole separate discussion. The main takeaway for today is going to be on MRI. Look for displaced osteochondral fragment or signs of instability. For instability, you're looking for a fluid cleft or fluid undermining the osteochondral fragment like we have here. Or some people describe exuberant cystic change subjacent to the OCL as a sign of more chronic instability. So we're going to switch gears away from ankle sprains and move on to something else. So get your phones or devices ready. So case number 4, this is a 63-year-old female with chronic diffuse ankle and foot pain. I will highlight the important areas to focus on. This guy here and this region here. So what is the diagnosis? Is this posterior impingement, lateral hindfoot impingement, a high ankle sprain, Charcot arthropathy, or a stress fracture? Okay, another 20 seconds or so. So let's move on. Okay, looks like about 53% of people got that right. This was a case of lateral hindfoot impingement, and we're going to go through that whole cascade now. So lateral hindfoot impingement, this is an umbrella term for extra-articular talocalcaneal and subfibular impingement that's going to happen due to chronic hindfoot valgus malalignment. So That hindfoot valgus malalignment can happen with congenital deformity, spring ligament insufficiency, but it's most commonly seen in association with an insufficient posterior tibialis tendon. That PTT runs behind that medial malleolus, has attachments to the navicular, the medial cuneiform, the bases of the metatarsals, and for that reason plays an important role in supporting the medial longitudinal arch. Injury to that PTT is going to cause that arch to drop, ending up in a pes planus configuration. And then let's go through that whole process of what happens now. So step one, you have a torn or insufficient PTT. This was a case that we had that had tendinosis, interstitial tearing, and tenosynovitis of the PTT. Once the PTT is not doing its job, that medial arch is going to start to drop. The talus will start pointing downwards, or talar declination, as we're starting to get here. Next, as everything starts to drop, you're going to end up in that pes planus configuration. This was a weight-bearing radiograph with a flat foot deformity. As everything medially at the ankle drops, the forefoot rotates out laterally, and you get uncovering of the talar head. We have this somewhat subluxation at the talonavicular joint, the forefoot pointing laterally. As all of that happens with that medial arch dropping, you go into a hindfoot valgus alignment. Normally on your mortise view of your radiographs or last few or posterior slices or CT and MRI, the talus, the tibia, the talus, and calcaneus are almost completely lined up. In this case, we have a clear valgus deformity. Once you go into that valgus deformity and everything's sort of out of alignment, you end up with pseudo articulations. So as that talus drops down, you're going to end up with a pseudo-articulation of the lateral process of the talus with the angle of Gissane on the calcaneus. This is not an articular surface of the subtalar joint. This is extra-articular, and that's why we have this kind of stress or this bone marrow edema, and sometimes you'll see cystic change across this pseudoarthrosis. So this is extra-articular talocalcaneal impingement. As you go into a severe valgus deformity of the hindfoot, the calcaneus may start to articulate with the lateral malleolus, and that is subfibular impingement. Similarly, you'll see bone marrow edema and cystic change across that region. Okay, next case. This is a 40-year-old female with lateral ankle pain, instability, and popping sensation. This is a touch question, so I'm going to have you click on the abnormality. And I'm sure this would be more clear if I was able to scroll through, but should be able to get it. Okay, another 10 seconds or so. All right, let's see how we did. Okay, looks like a good portion of people got it. So this was a case of a superior retinaculum tear with dislocation of the peroneus brevis tendon. So let's go over that. So the superior peroneal retinaculum, this is the primary restraint to peroneal tendon subluxation, is the confluence of the common peroneal tendon sheath, the superficial fascia of the ankle, and attaches to the lateral fibular periosteum. As that tears with forceful dorsiflexion, you can end up with a variety of subluxation or dislocation injuries to either peroneal tendon. And there are several different types of tears that happen with the superior peroneal retinaculum. Type 1 is the most common, where you just have stripping of the fibular periosteum, and that tendon can then sublux into that little gap. You may have a complete tear anteriorly, which is type 2, a complete tear with an osseous avulsion of the fibula at type 3, or a tear posteriorly of the retinaculum, a type 4. And remember, MRI is a static imaging modality. So this is where ultrasound may be helpful, as at the time of MRI may not be subluxed, but those dynamic circumduction maneuvers may help you see those peroneal tendons sliding up and over the fibula. Okay, peroneal tendinopathy, a little more bread and butter. The peroneus brevis tendon is going to be much more commonly involved than the peroneus longus tendon. And this can be acute or degenerative due to overuse, instability, ankle inversion injuries, or those retinaculum tears. These patients present with lateral ankle pain, instability, popping, clicking, or in up to 50% of patients may actually be an asymptomatic and incidental finding. For partial tears of the peroneus brevis tendon on MRI ultrasound is classically described as boomerang, C-shaped, or inverted U configuration, where that partially torn peroneus brevis tendon envelops that peroneus longus tendon. That can then progress to a longitudinal split tear. We end up with a complete tear through the central part of the tendon. And as the two parts of the peroneus brevis tendon separate, the peroneus longus tendon can actually fall into that gap. Those tears are usually going to be centered at the lateral malleolus. Peroneus longus tendon, much less commonly involved with tendinopathy, but when it does happen, it's usually a stress area. So at the peroneal tubercle of the calcaneus, as it goes under the foot at the level of the cuboid. Okay, switching over to some posterior ankle or heel pain. So this is a 12-year-old female with heel pain while playing travel soccer. She was recently immobilized for a metatarsal fracture, but recently returned to activity. So what is the diagnosis? Is this plantar fasciitis, an Achilles tendon tear, calcaneal apophysitis, reactive arthritis, stress fracture, or posterior impingement? Okay, another 10, 15 seconds. Okay, let's see how we did. Okay, so split between the two that I expected to be split between. The correct answer is a stress fracture. The reason for that, we have intense bone marrow edema centered at the calcaneus with a T1 hypointense fracture line. For calcaneal apophysitis, the edema is usually centered within the apophysis, possibly with a tiny bit extending into the calcaneus itself. Okay, next case, a 40-year-old female with chronic heel pain. So select the relevant findings. We have several findings. Should hopefully be relatively straightforward. Another 10 seconds. Okay, looks like pretty much everyone got that right. So this is a case of Haglund's syndrome. With Haglund's syndrome, you have the triad of the Haglund's deformity, which is the osseous protuberance at that posterior superior calcaneus, associated with Achilles tendinopathy, usually with tendinosis and partial tearing of the deep fibers, and retrocalcaneal bursitis, which we have here as well. We also have some reactive marrow edema within that actual deformity as well. Now, patients can have the deformity without having the syndrome. It's usually due to either tight-fitting footwear that leads to a kind of pressure on the Achilles tendon against the deformity, or repeated plantar flexion. The classic description is high heels that will lead to that same kind of friction response to that deformity against the Achilles. Okay, case number 8, 57-year-old male with chronic heel pain. Kind of highlight the area we're focusing on. And move on to the question. So what is the diagnosis? Lateral cord plantar fasciitis, Baxter's neuropathy, plantar fascial fibroma, a muscle strain, or a coalition? Another 10 seconds. All right, let's see how we did. Okay, great. So 50% got that right. This was Baxter's neuropathy. So lateral cord plantar fasciitis is going to be at the base of the 5th metatarsal, where the plantar fascia is going to insert. This was atrophy of the abductor digiti minimi muscle, usually seen with impingement on Baxter's nerve. Baxter's nerve is also known as the inferior calcaneal nerve. It's that first branch of the lateral plantar nerve coming off the tarsal tunnel. Impingement on that nerve may lead to denervation edema to start off, and then atrophy of the abductor digiti minimi muscle, where it provides motor function. Baxter's nerve is important because it also provides sensory function to the medial and a bit of the plantar heel. Clinically, it may be indistinguishable from plantar fasciitis. So in patients that have the symptoms of plantar fasciitis without imaging findings, but they have this atrophy or denervation edema, this may be an important finding. Okay, so let's run through all of the kind of important causes of posterior ankle and heel pain. We talked about stress fracture. This is going to be intense bone marrow edema at the posterior calcaneus. It'll usually with a T1 hypointense vertical or curvilinear fracture line posteriorly. Calcaneal apophysitis. This is what it tends to look like. You'll have edema centered within the apophysis, possibly extending into the adjacent calcaneus. Haglund's we talked about. You can remember you can have the deformity without the syndrome. The triad is deformity, Achilles tendinopathy, and retrocalcaneal bursitis. Baxter's nerve. So we saw that case with the atrophy of the abductor digitorum minimi muscle. And this is an earlier case where they have denervation type edema within that muscle. A little more routine is going to be Achilles tendinopathy, so degeneration of that tendon. Because the critical zone or that watershed region of the Achilles tendon is relatively hypovascular or avascular, it's going to end up, degeneration of that tendon will end up with enlargement of the tendon without actual increase in signal. Regardless, it's still a degenerated tendon, will be more predisposed to tearing. In this first case, we have some interstitial tearing extending into the distal fibers. In this case, we have a complete rupture of the Achilles tendon at that critical zone. Plantar fasciitis, a very, very common cause of heel pain. The plantar fascia is that big fibrous support structure at the bottom of the foot. It plays an important role in weight bearing by absorbing shock and providing stability. It also helps support the arch. Overuse, so excessive weight bearing, may lead to inflammation and micro tears within that plantar fascia. On MRI, it's going to most commonly present at the calcaneal attachment. You'll see thickening of the plantar fascia, most commonly the central cord or central bundle. And then in active or acute cases, you'll have perifascial edema, so soft tissue edema surrounding the plantar fascia, and then subenthesial bone marrow edema at that calcaneal attachment. As it gets inflamed and has micro tears, it can progress to larger tears, such as in this case. And last, for that posterior ankle and heel pain, we're going to talk about posterior impingement. So posterior impingement is going to be seen in patients that have an os trigonum or a prominent steata process. A steata process is an anatomic variant. We have elongation of that posterolateral talus. That posterior impingement is going to be seen in patients that do repeated plantar hyperflexion, so classically described in ballet dancers. This leads to impingement of that os trigonum or steata process against the talus, against the calcaneus, and the soft tissues. On MRI, they'll present as bone marrow edema within that ossicle, possibly with adjacent bone marrow edema in the talus or calcaneus, usually surrounding synovitis and soft tissue edema. Okay, last case for today. A 45-year-old male with medial ankle pain, worse after starting pickleball. Okay, so what is the diagnosis? Is this anterior medial ankle impingement, extensor digitorum brevis avulsion, a coalition with stress response, a painful navicular os, or a spring ligament sprain? Okay, got a couple answers coming in, another 10 seconds. So I purposely picked a somewhat atypical case. Let's see how we do with it. Okay, great. So the correct answer was painful navicular os. So we have a type 2 navicular os. This one's multipartite. It has a synchondrosis. It's somewhat atypical in that it's a slightly older patient, and that is multipartite, but it does have all of the findings. We have bone marrow edema within the os and across that synchondrosis with the marker sitting right over that area, and that's normally how they present. So painful navicular os syndrome, this is seen in patients usually that have a type 2 navicular os, which is larger than a type 1 and has a synchondrosis. It's more commonly seen in younger athletes. It's due to repetitive stress or tension on the PTT, which partially inserts on that navicular os. Rarely or less commonly, it can happen with direct injury. So injury to that region may destabilize the synchondrosis. Regardless of the mechanism, will present as stress across that synchondrosis. And as it becomes more of a chronic process, degenerative changes across it. Some smart guys over at Jefferson came up with a grading system for this to help assess severity and possibly guide treatment. So we talked about that case right there. So it's technically a midfoot case, but remember, patients are not really going to differentiate midfoot versus hindfoot, and the midfoot is covered on your ankle MRI, so always keep that in mind. So sometimes these seemingly inconsequential structures, like your os trigonums or your navicular os, may be a cause of pain in the ankle and midfoot. The last one I just want to touch on is a painful os peroneum. similar to the painful navicular os in that it's a repetitive stress injury to that ossicle. In this case, that os is embedded within the peroneus longus. Repetitive use of that peroneus longus may lead to inflammation and bone marrow edema on MRI within that os. The last kind of variant that I want to talk about that may be a source of pain in the foot and ankle is coalition. So as opposed to the wrist, where coalitions are generally asymptomatic, the tarsal coalitions, because it is a weight-bearing joint, may lead to altered biomechanics and various stress responses. In the foot and ankle, the most common coalitions are going to be calcaneonavicular or talocalcaneal coalitions. These can be fibrous, cartilaginous, or osseous coalitions. It can be difficult to distinguish between fibrous and cartilaginous, so you may hear people just say osseous versus non-osseous. In this case here, we have a non-osseous calcaneonavicular coalition. On MRI, we can see that coalition on our T1 weighted sequences. In this patient, it was clearly the source of the pain as I have this intense edema spanning that coalition. Okay, so that was a brief but hopefully thorough review of ankle-specific pathology with a focus on acute injuries and painful conditions. There are additional ankle-specific things that I didn't talk about that you should keep in mind: congenital abnormalities, additional tendon pathologies. You can get direct contusions, crush injuries, impaction injuries to the foot and ankle. And then, of course, midfoot and forefoot pathology that may get imaged or may get referred back to the ankle. So stress response in your midfoot, stress response at the base of the metatarsals, and on occasion, Lisfranc injuries. And then, of course, things that happen in other joints can happen in the ankle. OA, inflammatory and crystalline arthropathies, neoplasms, PVNS, giant cell tumors, lipomatous tumors, and neurovascular pathologies. All right, thank you very much. Happy to answer any questions.
Right, so I'm monitoring the Q&A box and we don't have any questions yet, but I'd like to, emphasize the importance of checking the lateral ankle when you have patients with acquired pes planus deformity. Many times patients actually showed up to have their MRI examinations performed, and they point to the lateral ankle as the site of complaint when the PTT is completely disrupted medially. And that takes place due to what you very nicely explained: the lateral hindfoot impingement is going to cause compression of the fibular calcaneal space and entrapment of the calcaneofibular ligament and peroneal tendon. So that clinically is something that happens and happens often, and we need to keep in mind. All right, so let me go to the Q&A, and it's still empty. I really enjoy doing poll everywhere, and I thought that there was a very nice selection of cases to go over. One thing with os navicular, we see it so often, right? So there was a nice paper published by Sarah Kamel from your institution and collaborators. Did they find increased association of posterior tibial tendon tears with either type of the ossicles?
For that paper, we didn't look at that. We're mostly just looking at reproducible grading system. Anecdotally, I would say yes, but I don't have any data to support that.
Yeah. So, I mean, typically what happens is there is a fulcrum mechanism. And if you remember physics, I was terrible in math, but actually good in physics and enjoy physics during high school. So if you can imagine the PTT going around the medial malleolus, the retromalleolar groove, that point is the fulcrum for the PTT. If you have a type 2 or a type 3, that will significantly decrease the length of the tendon between the fulcrum and the site of insertion. So it places there is increased tension within the tendon fibers, because of that. So there are many reports that describe the association of type 2 and type 3 with posterior tibial tendon tendinopathy and tears. So people are very quiet tonight, and I know a few people who are in the audience and they tend to ask questions. Come on, let's see. Let's refresh the Q&A. All right. Okay.
I was too thorough.
Yes, you did such a nice job that no one has any questions. Okay, I think I've seen something popping in the chat, so thank you. That was great. It was a nice presentation. Sorry, not such a question. All right, thank you. Let me go to the Q&A, and the Q&A is in the protocol. Thank you, it was a great review. Do you usually acquire a specific, I think the question is coming in pieces. Yeah, no, I think you'd like to know if there are any special planes of imaging that you recommend besides the, standard MR plane. So we have the oblique sagittal that goes along the lateral calcaneal wall, and many of us do anatomic and fluid sensitive sequences in the sagittal plane. And then we have the short axis or coronal plane through the hindfoot. And we have the axial images. So are there any special, imaging planes that you recommend in certain situations?
Generally, we are, with most ankle sprains, the patient's not really providing useful information. So it's a routine ankle MRI. So it's more of a figure out as you go. Usually the routine ankle MRI will get you to the diagnosis, whether it's a partial tear, complete tear of any of these ligaments. I suppose if you needed follow-up imaging for whatever reason, you could do more specific. Ultrasound is also quite good at looking at all of these ankle ligaments as well, so also can be utilized along with doing dynamic maneuvers for that.
Yeah, we actually recently Jonathan Sterman is one of our new faculty attendings, and he incorporated a routine oblique axial for the ankle. So it's basically a perpendicular plane to the PTT and the peroneal tendons in a fluid sensitive sequence, fat SAT-T2. And the idea is to try to minimize magic angle phenomenon, because you almost always get it with a straight axial. And then you can also, see better within the tendons if there are split tears or, any intra-tendon abnormality. It's, much better visualized. And I agree. I mean, it replaced, we retain the axial anatomic sequence, and now we're doing the fat SAT-T2 in the oblique axial plane. It takes a little bit of getting used to it, but I must say I like that new thing.
I can imagine that being quite nice. I know that kind of right at that lateral malleolus, when you look at those brevis tendons, is right where you get that magic angle artifact. Some of our extremity,
yeah,
we have some extremity scanners where they end up as slight oblique. And that actually makes it quite easy to look at the peroneal tendons. So that's actually that would be a great sequence to add in.
Yeah. And I think Dr. Medjin was also asking about 3D images for the midtarsal sprain. So if that could be applied.
We generally don't do 3Ds for the ankle. I think it would probably be a very time-intensive sequence that we don't really, with the volume that we put through some of our scanners, probably not a useful sequence to get, especially because you can probably diagnose those injuries on multiple planes using just a regular routine protocol.
All right, so now we have questions in the Q&A. When is a calcaneofibular ligament too thick?
I don't have a good answer for that. Usually if there's scarring of the calcaneofibular ligament, there's usually a change in signal. There's usually a little more heterogeneous in appearance, might be some granulation tissue around it. So not quite that black ligament that you would like to see. And I'm sure there's variation from patient to patient.
We have Dr. Canuro's syllable. How do you differentiate complete and incomplete tear of the ATFL ligament?
So usually the axial is going to be the best for that one. And, the oblique may help for that. For us, we just have the anatomic axial through there. For the ATFL, you'll usually see, a little bit of fiber still coming through if it's a high-grade partial tear. If it's a sort of a low-grade partial tear, more of thickening and intra-substance signal. Complete tear, usually there's complete loss of that ligament. And if there's injury to the capsule, you maybe see some joint fluid pooching out through there.
Thank you for the talk. What do you make of bone marrow edema in the calcaneus just below the sinus tarsi? I think
So we're talking about lateral hindfoot impingement, I guess.
so it's marrow edema in the calcaneus just below the sinus tarsi. I think it has to do with the nutrient channels that we very often see in the angle of Gisan. You may have tubular T2 signal due to nutrient channels in that location. And sometimes it gets actually, people develop these cystic changes around nutrient channels that sometimes can also have a little bit of marrow edema. So that's often seen there. And also, as Vishal was saying, if there is teleocalcaneal impingement, we tend to see also marrow edema on the opposing talus and calcaneus surfaces. And they are not articulating there, it's just the opposing surfaces of the talus and calcaneus. Okay, we have another question. Is it possible to have symptomatic plantar fascia findings, as in if patient doesn't report heel pain, but there are intrafascial signal or thickening?
Yeah, I think one of the things I was trying to discuss is the ankle. A lot of people have had ankle problems, and those imaging findings kind of stay around for a long, long time or forever. If you had some sort of injury to that plantar fascia in the past, if you had plantar fasciitis years ago, usually the plantar fascia is going to remain thick. So thickening doesn't necessarily mean pain. It may just be somebody that had plantar fasciitis in the past. Usually we'll differentiate between acute or active plantar fasciitis when you have that soft tissue edema, that perifascial edema, and then the bone marrow edema at that calcaneal attachment.
Wonderful. And one last question in the chat. Do you recommend we should give gadolinium in ankle MRI in any specific clinical scenarios? So use of GAD.
So for us at our institution, I think probably most places, gadolinium for MSK MRI is mostly reserved for tumor evaluation and occasionally for inflammatory and infectious causes. For most of the things that I discussed today, I would not use GAD for that.
Okay, we're going to take one last question. Two last questions, and here we're going to stop. So the first one is, if there is marrow edema at the plantar calcaneal and tesophyte, but plantar fascia looks normal, is it still plantar fasciitis? So you have edema, the plantar fascia looks normal. Do we call that plantar fasciitis or not?
I generally would. So acute plantar fasciitis, so prior to them developing thickening of the plantar fascia, may present as just perifascial edema or that subenthesial bone marrow edema. As it goes on longer and longer, it'll get thicker and thicker. So yes, I probably would, but it is also a clinical diagnosis, so make sure they do have heel pain.
Yeah. Yeah, it could be just enthesitis from an inflammatory condition, systemic inflammatory condition. Okay, and last, Nick DeSanti is asking, what makes the midtarsal sprain a relatively commonly misdiagnosis? Is it just a bit of a common blind spot,
I think so. I mean, it's one of those things where year after year with our fellows, it's, I've seen enough of them. I pull it up. I recognize that the fellows have gone through it. They'll make one of the findings and miss the rest. It's a difficult spot. You're not always looking at that calcaneocuboid joint on your sagittal. You're not always looking at that tilo-navicular, that tiny bit of edema. You get satisfaction of search seeing that anterior process calcaneus avulsion fracture without actually looking for the additional findings.
Great. Thank you so much, Dr. Desai. So this is the
Yeah.
moment where we are going to see a survey link in the chat. And it is very important that everyone, that's your homework, fill out the survey. So that will give us feedback on this session and on the program itself. I'd like to thank you for staying with us. And hopefully now we can all have a nice dinner. Also to remind you that in January, we will have Dr. Erin Alaya talk about knee chondral resurfacing. I have to talk a little bit about Erin. Erin trained as a fellow at NYU when I was faculty there, and she's also a former Montefiore Radiology resident. Now I know why she's so great. My Montefiore Radiology residents are absolutely the best. Please don't get jealous. Those residents who, may be out there or faculty who train with me at MGH or NYU or Penn, but Montefiore residents are really, really strong. And I'm sure she's going to give an amazing talk. So that's January 15, 2025 to start the new year at 7 p.m. And thank you very much. And I think that I'll let Dr. Desai say goodbye for the night. And we really enjoy spending time with you tonight.
Yeah, thank you very much for joining us. I know joining in the evening is always difficult, but hopefully you gain something out of this, and feel free to reach out if you have any questions.
Great, thank you.